what we've learned in the world of psychiatry is that gabapentin can work really well for anxiety. And so as a psychiatric provider who takes care of patients with dementia, I oftentimes use gabapentin to help with the anxiety that goes along with it. That's a nuance of that medication. And that's something the clinician makes the decision. Now you go see the pharmacist can't talk to you about off-use medication, label medication. That's not his job. His job is to know how that medication works and how it interacts with the other medications that you're taking. So again, asking the pharmacist depends on what the question is you're asking the pharmacist. So if you say to the pharmacist, my doctor put me on this medication, here's my other medications, are there going to be any interactions? That's a pharmacist question. If you say to the pharmacist, will this medication make me sleepy? Should I take it in the morning or should I take it at night? That's a pharmacist question. Should I take this medication for anxiety even though it's indicated for neuropathy? That's not a pharmacist question. That's a clinician question. So it depends on what the question is that you're trying to find out. Just as I talked about all of the different members of the team, you want to ask the right member of the team the right question, right? If I asked the cardiologist about my diabetes, I can't be upset with the cardiologist that he's not going to answer that question correctly. It's not his area of expertise. So it's the pharmacist's job to help you know when to take the medication, what might interact with the medication. There are several medications that interact with grapefruit juice, right? I'm sure you've all heard this before, right? So it's the pharmacist's job to let you know, hey, you just got started on this medication. I know the label is going to be on there, but I want to remind you, if you're a big grapefruit drinker, you don't want to be taking that with this medication because it's going to alter how you absorb it and how well it works. Those are pharmacy type questions. Okay, does that answer that for you? As a provider, it's always a little frustrating when a patient comes back to me and says, well, the pharmacist says I shouldn't take this. Okay. Well, I'm still the clinician and I still think that was the right medication for you. So I disagree with the pharmacist. Now, sometimes the pharmacist will have a good reason. And they'll say, oh, yeah, because I'm taking this. And I'm like, did I know you were taking that? Because I might not have known that there was a new medication that you started and the pharmacist picked it up. Sometimes I had a patient the other day who was on a very high dose of the medication. And the pharmacist called me and said, are you sure this is what you want to put them on? And I said, let me go back and pull their records. And I did. And the patient had been on that dose by a specialist for several years. And that was the appropriate dose. And so the pharmacist was like, that's great. But it was a double check. I appreciate that when the pharmacists do that for me because it wasn't a medication I was familiar with. And the patient was moving into a memory care unit. And I was just doing their full med list. And it wasn't something that I would know. So in those situations, the pharmacist can be very, very helpful. Okay. Yes. That's a really good question. So the question was, when do you know when it's time to bring in palliative care? You know, I do a lot of talks on the staging of dementia, right? And I'm assuming you're talking about with somebody with dementia. So, you know, I look at the behavior patterns and what we're seeing and when it's appropriate to make that sort of shift. And I do it based on the stage the person is in dementia. For me, stage 6 is really when we kind of start to get to that point where palliative care is more important. Now, having said that, I have had people say to me, even when their loved one is in stage 5, I don't want them on cholesterol medication. I don't want them on their diabetes medications. I want them on as little as possible, and I want to let the disease and their other chronic illnesses take its course. So I think it's a very personal choice, and I don't necessarily know that there's a wrong answer to that question. But we also have to remember that there can be consequences to coming off of those medications. So if you're taking a cholesterol medication because you have a history of stroke, and we're trying to keep your cholesterol down so that you don't develop more arterial sclerosis or damage to the vessels in your brain, and you have another stroke, but it's not a stroke that takes you, it may just debilitate you more. Now, what have we done to the quality of your life? So again, there's not a one-size-fits-all answer to that. But when we get to that later stage, when we get to stage 6, where they really are struggling with recognizing who you are and holding their urine and being able to feed themselves and dress themselves, then really do they need the cholesterol medication? Really do they need it? Like, let them have a cookie. It's the joke here at Town Square because I say that about all the diabetics. Let them have a cookie. I don't really care what their blood sugar is. Blood sugar control is something that we control tightly in our younger diabetics because we don't want to cause them damage to their eyes and their kidneys and all of their nerves, all of the other things that elevated blood sugar does. But when you've got a couple of years left to live, we know that you're at the end stage of dementia. Does it really matter if you have a cookie? Now, I don't want you to have a blood sugar of 500 and go into diabetic coma, but most of these people are still on their diabetes medication, and all it's going to do is elevate their blood sugar, but not necessarily cause them a life-threatening issue. So again, it's degrees. It's degrees. When we get to the hospice stage, that's really when they're struggling. Like they really. The other thing you need to understand about hospice too is that hospice can happen anywhere. It can happen in your home. It can happen at the hospital. It can happen in an assisted living facility or in a memory care unit. And hospice provides tremendous supports. They have social workers and they have pastors and they have CNAs and they have, hospice docs and nurses that are clinicians that will come in and evaluate your loved one and help be those clinical eyes. That's not your job. Your job is to be the wife, not the clinician who's taking care of this person. So having that hospice person can be very, very helpful. Having the durable medical equipment that hospice provides. They'll bring that hospital bed right in within 24 hours. You call and you say, my loved one needs a hospital bed, it's there. The high back wheelchairs. I have these 6-foot men who, need these big. You can buy those wheelchairs, at the medical supply store, but the high back ones that really help tilt them back and make them comfortable, hospice can get them there. The raised toilet seats, the commodes that you need, and the big truck shows up and it's in your house. And you don't own it. You don't have to buy it. There's no cost to you. It's covered under Medicare. And then when you're done with it, guess what? That same truck shows up and off it goes. So you don't have to worry about getting rid of it or what am I going to do with this hospital bed or all of that kind of stuff. And they can act very quickly in terms of getting medications. Say you need morphine or Ativan, pain meds, medications for any other types of issues that come up during hospice. They've got a pharmacy that delivers the stuff to your house right away. So again, it can be hugely helpful at end of life to really have those people there. And they're going to come in and they're going to help you understand what you're seeing. When is it time to stop offering food and drink? When is it time to just make them comfortable? And what are the signs that this person is actively dying? Because that's really important for you to know. So you know when to call the family and say, time to get over here to see dad for the last time. So there's the palliative. So hospice does offer sort of a palliative level care. But again, the hospice can be as much as you want or as little as you want as well. I have some people, we have quite a few members here at Town Square that are active with hospice. And they're active with hospice because their families needed that additional support at home, needed those. But they're still coming to Town Square every day and they're still participating in life, right? They're not at that end stage. Right. So it doesn't, and that's the most important thing that I try to get people to understand is that we bring hospice in when we're getting close, but we don't wait until, the last week of life. We want to provide you with those resources beforehand so that you have them there. Hospice has certain criteria that they have to meet in order for you to qualify for their services. So they're going to be looking at what stage of dementia you're at, whether or not you've had a weight loss, whether or not there are other debilitating, you went from being somebody who could walk to somebody who's now bedbound. These are all of the qualifiers that you can, have to have in order to receive the services. And like I said, we have had people who have gone on to hospice services. We clean out the meds and they pop up and they do well, or I come in and fix their psych meds and now all of a sudden they're eating and they're not losing weight. That happens to me a lot in the memory care units, where we clear out all the meds and I come in and say, okay, she's not eating, let's just do this, this, and this. And, 3 months later when it's time to do the recertification, now all of a sudden they're eating and they gain some weight and hospice goes, got a discharge. But that doesn't mean that if she takes a turn for the worse in the next week, I can't call hospice back and they'll readmit her. So, again, it doesn't mean you're on it until you pass. You might actually get a little bit better and not need it. Or if you are one of the ones who does stay on it, I've had people be on hospice for a year because the decline is slow and steady and they keep meeting the criteria in order to stay on hospice. But I think the average hospice admission is like 11 days. It's short. It's short. Because a lot of times, families do wait. Yeah, a lot of times families wait until the person's practically got their foot, and they call in, and hospice is in there for 24 hours. So, that's why I like to try to get all of that stuff in there beforehand. We try to be proactive so that you have that support available to you. Anything else? Questions? No, palliative care is more of an approach. Your own primary care can handle the palliative approach. You're not going to get the durable medical equipment and all the supplies that go along with it. That you actually have to sign up for hospice. And hospice is actually, it's a Medicare program. So like everybody who has the Medicare Advantage plans, if you sign up for hospice, you actually go back to straight Medicare and your Advantage plans become secondary. And through those Medicare dollars, Medicare gives the hospice company a stipend for the month, and out of that stipend, that's what they provide your services for. So it's, and then if you wind up going off hospice, then you go back to your Medicare Advantage. If you were on straight Medicare to begin with, then it really doesn't change anything, but it does change for the folks that are on the Advantage plans. A lot of people don't understand that hospice is actually a Medicare product, and it's paid for by Medicare. When people say, well, it's going to cost me money to do that. It costs hospice money to do that. And it's their job to utilize that money that they're given for that month to provide services, which they do. They do. I've not had a problem with the hospices down here, withholding care or whatever because of the money. I actually had one patient say to me, well, they sent a social worker and they sent the pastor. They're just trying to run up the bill. And I was like, well, actually, that's not the way it works. No, they're actually spending their money to send those people out. It's part of the service. So, and for the longest time in Manatee County and Sarasota, we had one hospice. We had Tidewell. Yeah, which is crazy because, in many other parts of the country, there's 10, 12 hospices in an area, lots of competition. Probably about 5 or 6 years ago, Affinity Hospice came in. They started out as Continuum, then changed their name to Affinity. It's been interesting. So now we have 2 hospices, which is at least a little bit helpful because there's some healthy competition and it kind of raised the bar a little bit as to what they could do. The biggest problem's been is that there's, as I've already said, like in terms of the social workers, there's a finite pool of healthcare providers, LPNs, RNs, and the like. And now I got 2 hospices that are kind of competing for those employees as well. And so as Affinity has grown, sometimes they've had a little difficulty finding nurses, and so they're short-staffed, and it's because they're growing rapidly. And with any rapid growth comes difficulty staffing. So that becomes an issue as well. Whereas Tidewell is a foundation that has been around now for years and years and years. So they're a little bit more stable in terms of that. So there's been some growing pains. But again, these are all those nuances that are very hard to know as you navigate the system. So, but your healthcare provider should be able to help you with making some of those decisions. All right. All right. Thank you. I have new member orientation for